Okay, folks, we're back. I'm your host, BKP. We're at Circuit World here in Blue Ridge, Georgia. A beautiful Friday morning, and it's now time for Ask the Doc with Dr. William Whaley, brought to you by Georgia Cancer Research Center, affiliated with Northside Hospital. How are you today, Dr. Whaley?
Great. Yourself?
Good. We have, that is a very nice red, white, and blue tie. Very nice.
I'm wearing that actually in honor of a very senior physician who died in Atlanta. His name's Ernest Beasley. Ernest was in his 90s, saw patients till he was 89. He was an enlisted man in World War II, came back, went to medical school, was in the reserves, got married, and 2 weeks later they sent him to Korea. So he was he did his part. He was always interested in conservative things and in military service. So anyway, I'm going to run down to Atlanta tonight and wear my tie in honor of Ernest Beasley, the elder. Because Ernest Beasley, the younger, his son, still has his practice. So
well, that's a very nice tie. I mean, you know, that's a nice tie. I like that.
I appreciate it.
I like that flag this morning.
Hey,
yes, sir.
You're going to have a pet as part of the All-Star panel. Is that what I heard? There's going to be a pet of the week and the All-Star panel on here together, or is that different?
No.
Oh, it's different. Okay.
Okay.
There's no puppy dog here for the.
No. But
okay.
we could do that. That would change things
yeah,
up.
Jay would love it. Yeah. All right. Okay. Go.
Our first question today, and this comes again. We thank Georgia Cancer Research Center, affiliated with Northside Hospital, and I'm going to read it and I'm going to try it. And I know I have these syllables backwards and they're not working, but I'm going to do it anyway. I have been having severe and chronic stomach and digestive troubles. So as part of the treatment course, the doctors just took a biopsy. They said the test results should show intestinal
Metaplasia.
Intestinal metaplasia. And I understand that this is a warning for future stomach cancer, but is metaplasia but what is metaplasia? How do I find it?
All right. First of all, this is a really good question. I kind of like the question that opens up the spectrum of things that at the end of the day can be serious and cause cancer. And this issue here, first of all, you don't fight it yourself. If you have intestinal metaplasia, you're going to be in the hands of a good gastroenterologist, and it is going to be a continuing program of observation and maybe testing. So show that first picture if you would, Josh. This picture, BKP, we're showing it just because of the beautiful blue and purple colors. But this is a biopsy of a stomach that has a whole bunch of glands and stuff in there that doesn't look like what you see when you watch those commercials on television about the Zantac and everything.
Right.
And it shows the little hairs in there. So metaplasia means that the surface of the stomach lining has been changed. That's plagia. And generally it is associated with a loss of stomach acid. So you don't make the normal stomach acid. Intestinal metaplasia does not cause any symptoms. You would not have, what would she say here, severe and chronic stomach and digestive problems from the intestinal metaplasia. The fact that you don't have any acid in the stomach would mean then that bacteria and things that you normally eat that your stomach is going to kill before they get into your small bowel because of the acid don't get killed. So you get bacterial overgrowth in the stomach. You can then become anemic. You can bloat, you can belch and all of that. Well, that's not the intestinal metaplasia, that's the low gastric acid. So we'll begin with the fact that the metaplasia can be anything from just a small amount in a small piece of the stomach. We're going to show something in just a minute, or involve the entire stomach, but it's not causing your symptoms. Josh, if you would next show that big old chart. I love to show these charts because what they tell you is there's a pathway. So here we know this patient has a gastric biopsy that shows metaplasia. The very first thing you do is look for that bacteria that causes ulcers. You remember me talking about that? So if you've got that bacteria, you treat it, the metaplasia may go away. So that is, how do I fight it? Frequently then, that means that it's not permanent metaplasia, it's the result of that bacteria. But after that has been done, the next question you've got to answer is this an isolated thing or is it extensive? So Josh, you're going to show that next picture. This is easy to see. This is a map of the stomach. So you really want to know how much of the stomach is involved with intestinal metaplasia. And if you just have one biopsy that shows that, is it worth going back and biopsying all parts of the stomach to make a map of how much of the stomach's involved? And the risk of cancer from intestinal metaplasia is really quite low, all right? The overall progression to gastric cancer and intestinal metaplasia is overall low. That's 2.5 cases per 1,000 person years. Now that's a strange way of putting it, isn't it? But it depends upon what are your real risk factors. The biggest risk factors are actually sort of racial, ethnic, and dietary. You know, it was just a few weeks ago I talked about the fact that people who eat Japanese hibachi type diets get more in the way of gastric cancer, and that stuff about buying your steak and putting it on the charcoal broiler. So if you are non-Caucasian, and particularly if you happen to be Asian and first generation, if you were it's not your parents came over here from Japan or somewhere, or your parents came from the mountains of South America or from the mountains of Africa, even if you were born here, you're at increased risk of gastric cancer from intestinal metaplasia. So you've got to look at the risk factors in terms of genetics. Did anybody in your family have gastric cancer before? What is your ethnic background? What is your diet like? But if you have hit any of those risk factors there, then that gastroenterologist is going to go back, and sometime within the first 18 to 36 months, he's going to go back in here and make that map. Then once he's got that map, if there's only one little piece that's involved with intestinal metaplasia, you really don't need to do anything. You're going to make sure that make sure that you're not doing anything that's going to hurt your stomach, but you don't have to do anything specific. But if you've got a significant portion of the stomach, you'll notice they got a little line there.
Right.
If you've got the upper stomach and the lower stomach both involved, they're going to do a scope job every couple of years. They're going to biopsy you every couple of years because they're going to be monitoring the chances that you get gastric cancer. But you got to go back. 2.5 cases per 1,000 patient years is not a very high risk, but it's certainly a lot greater risk than the average guy. So there's no specific drug to treat it. You really are going to get into a monitoring program by a good gastroenterologist. The symptoms that you were having that got you to this diagnosis are not caused by the metaplasia, but may be caused, as I say, by the bacterial overgrowth for not having enough gastric acid. Well, in that situation, they're going to treat the bacterial overgrowth with antibiotics. They're going to have to give you vitamin B12 shots because you don't make vitamin B12 if you don't have any stomach acid. So they'll be treating those things and treating your bloating. But basically, at the end of the day, once you've got intestinal metaplasia, you've got to be in the hands of a gastroenterologist that does scoping, and you're going to be out of the hands of Dr. Tidman or anybody like that, and you don't fight it so much as you observe the course of it. Is that too much, or is that all right?
That's all right.
Josh, that okay? Got it?
I think we
that
got
was
that.
a pretty picture, wasn't it?
I think we got that.
All right. Okay,
and
don't want to get you.
No, I think we have that. Georgia, we want to thank Georgia Cancer Research Center affiliated with Northside Hospital for this segment, and they bring us our second question of the day. What could be causing pain in the left side of my head and ringing in my left ear?
All right, we want to separate the two.
Okay.
All right. We're going to separate the two because tinnitus, which is the ringing in the ear, is an extremely common condition. Hey, how many people do you know complain of ringing in your ear? Okay, we've got 6 adults here, 5 of which are over the age of 40, and 1 of them raised their hand. Well, that's exactly the right number. 50 million people in the United States have tinnitus, continuing tinnitus. That 1/4 of them, that'd be 12.5 million, it actually interferes with the quality of their life and their daily activity.
All right, slow down. So we're dealing with ringing in the ear right now. Now, people say ringing in the ear. Now,
let's say ears.
Ears. Okay, is it equal to buzzing?
Yes, same thing.
Is it the same thing?
Yeah.
Okay.
And there's lots of different ways of describing it. So,
because there's times I have just that minor buzz, not catch a minor buzz. Whoa, for those on TV, I mean in the ear. Just minor.
Understand. At the age of 50, your hearing begins to deteriorate as your acoustic nerve apparatus begins to deteriorate. All right, since I just said acoustic nerve apparatus, it's time to put up this next plot here. All right. Now, you can't answer that there unless there's a national emergency. You got to look at this complicated diagram you got here. It's got up on the screen where everybody can see it. Okay, at the top of the diagram are 2 circles there. That's the auditory cortex. That's the part of the back of the brain that listens to your ear. And way down here in the bottom on the left, that little plug that you see, that's the actual ear mechanism itself. This little next thing here where it says cochlear nucleus, that's where Rush Limbaugh has that thing.
Right, cochlear implant.
Right. Yeah, okay. So anywhere along this apparatus, something can go wrong and can cause the ringing in the ears. But the most common about the ringing in the ears, you can take that down, Josh, it's too complicated. But the most common part of ringing in the ears is an S, ringing in both ears. And that is what generally this 50 million people are complaining about. It can occur because of medications that you take. For example, aspirin, if you take too many, makes you ring in your ears. At the age of 50, everybody's hearing begins to deteriorate, so these fancy stereos in here that have all this 20,000 cycles per second are wasted on me because I don't hear too terribly well. And when your hearing begins to deteriorate and those nerves begin to wear out, the result is a ringing in the ears. All right, so we aren't to this question here yet. This question is a unilateral, 1 ear only, left ear, doesn't hear well.
Right, okay.
All right. So that tells you that it's not a systemic thing like my ears are getting old, or it's a medication, or it's a sinus congestion or something like that. There is probably something in either the ear itself where the bones are, or in that process of nerves that runs all the way to the brain that's amiss. So this is something that you've actually got to get in the hands. Family doc can't do you any good. You got to get in the hands of an ear, nose, and throat physician. There's a guy down in Atlanta that has a whole institute on vertigo and ringing in the ears, and it becomes complicated. The fact that it's in 1 ear only says go get it looked at. Now, I had a physician's assistant who was actually the first physician's assistant in Georgia, who had an acoustic neuroma, which is, and I think we talked about that maybe 6-8 months ago. Acoustic neuroma is a little growth along the course of the nerve, not unlike the Morton's neuroma in your foot or the neuroma in your hand that causes pain, that is unilateral, can cause ringing in the ears, a decrease in hearing, and problem with balance. And that's a benign thing if it doesn't get big, but the only way to diagnose it is to get a scan of your brain. So the next question was about pain or sort of a unilateral headache. What it said was pain in the left side of the head. So you've got to dissect that out somewhat. But if they're talking about a pressure up here on the left side of your head and that ear's ringing, then the first thing you got to worry about is, do I have an acoustic neuroma? is there some sort of an anatomical thing in that one half of that chart that Josh was showing here a few minutes ago. And the number of things can be all the way from just sinus and eustachian tube in one ear, like you'd get if you went diving. But I've got the sense from listening to this that it's not short term. I mean, when you listen to that question,
yeah, exactly.
It doesn't act like it's just a week, right?
Right.
It acts like it's a chronic condition.
It's a pain and a ringing, and it doesn't seem like it just happened.
Yeah. Okay. Right. So if it just happened or it's been there a week or two, it could be a sinus. Go see Dr. Tidman. But if you're talking about 3 months and it's getting gradually worse, and I got the sense it's doing that, it's bothering them.
Yes, that's
it's interfering with the quality of their life. Right?
I'll agree with that. It's not just something that just happened for 2 or 3 days. It's something that's really consistent.
Okay. Now, I went back over here and said 50 million people have got the tinnitus. It interferes with the quality of the life of only 25%. I've got the sense that it's interfering with the quality of life of this one. So that puts it in the more serious category that you need to be in the hands. And Tidman can send you to a good ENT, but it's going to have to be an ear, nose, and throat physician who's really kind of tuned in to the Rush Limbaugh-like physiology, and not just a guy who straightens out your septum and does a bunch of tonsillectomies. So you're looking at a subset of ear, nose, and throat physicians who have experience and expertise in this. Josh, was that too much? Okay, so it's as simple as something wrong with your sinus. If it's short term, it can be tumor on the nerve, if it's acoustic neuroma, or anything in between. But if it's lasted longer than a month or two, don't go see. Let your primary care doc send you to the ENT. Is that got it? Is that good enough?
Absolutely.
All right, we got that.
All right. Now, this is always at this time, Dr. Whaley shares with us something that may be new out there in the medical world that we need to know about. I do know they're putting, romaine lettuce back on the shelf today.
Yeah, right. Yeah,
so,
right.
And we've talked about that a while back. So what do you have for us today?
All right. Well, I got it every week here. Last week I was showing exercise decreases the chances of almost every kind of cancer. I hate to tell you, but in yesterday's, and I think you'll probably see this in the news the next day or two, increasing amounts of belly fat cause dementia. So this huge study is on people who live in England. So people who live in England are sort of culturally and genetically equivalent to us, right?
Mm-hmm. Okay.
You got 10,000.
I'm staying with you so far.
Okay, you got. I mean, this is not 23 and me or any genetic stuff, but I mean, the Caucasian, Anglo-Saxon, Europeans. So
right.
There are 10,000 of them. That they measured the bulk of the brain and the degree of obesity over the course of a decade of life. And as obesity went up, brain density went down. And the people who remained at lean body weight, their brain density stayed the same. So that the fall in brain density was not equilibrated to the increase in 8 years in 10 years unless it was associated with an increase in body fat. Does that make sense?
Yes.
So baby, when your calories are going to make body fat, they're coming out of your brain. Is that terrible? All right, now.
Go right ahead.
All right, now, you heard this first 2 weeks ago, and it was a huge thing yesterday. I even saw it on Fox. That over the period of Christmas, as I told you, the flu epidemic hit. There's a lot of accelerated deaths that have started right after Thanksgiving. But there is, I've continually said, the difference between flu and a flu-like illness. The flu-like illness is an epidemic of it going around that the flu shot does not prevent. All right? It is the arbovirus that causes the common cold. When somebody is sick as a dog, their temperature's 103, and they feel like they've been hit by a 2x4, and they go to the emergency room with a primary care doc, they don't really need to have the swab test for the flu because clinically they've got the flu and they need to be treated. But this illness that gets you sick for the same amount of time, this illness is going around right now, the flu-like illness, has a 3-day to 3-week duration. Well, the real break-bone flu usually is a week to 3 weeks. So right now when people say, well, flu shot doesn't protect against all sorts of flu, that's the second set of illnesses. And it's still, as of today, it's worth getting your flu shot. The epidemic is on an uptick, and if you get your flu shot now, maybe it'll keep you from having a bad case in March. And so you'll hear a lot about that in this week. Anything else?
Sounds like that's about it.
All right.
I appreciate it very much. Thank you, Dr. Whaley. Don't forget, folks, out there, if you have a question for Dr. Whaley, you send it to info, I-N-F-O, info at fetchyournews.com. Put in the subject line there, Ask the Doc, and we'll get that to Dr. Whaley. Don't hesitate. Send any question, and we'll get those right over to Dr. Whaley. Info at fetchyournews.com. We want to thank Georgia Cancer Research Center, affiliated with Northside Hospital. I appreciate you very much every week doing this. I learned so much, and I know the viewers out there do also. I appreciate it.
Well, your All-Star panel's not going to have a dog with it, though.
No.
Maybe next week.
I don't know. We may have to add something in to get this thing livened up because, you know, I don't know. We have nothing to talk about.
You said you had Pet of the Week, and this is I thought the Pet of the Week was going to be part of the thing.
This is plural.
Okay.
These are the pets.
All right. These are pets. All right.
All-Star Pets. Right after this, the All-Star panel. Wonder if we have anything to talk about. Rick, Bruce, Candace, and Jane are with us on the other side of these messages. Thank you very much, Dr. Whaley.